Okay, let me go back to my title slide. We're talking about infertility, defined as the failure to achieve a pregnancy within 12 months of well-timed unprotected intercourse. They changed that definition if the female partner is 35 or older because they don't want people to delay seeking treatment. Once a woman hits 35, fertility declines, and so your chances of achieving a pregnancy are lower. It impacts 1 in 6 people around the world at least once in their lifetimes, and it can be defined as primary or secondary. Primary infertility means that you have never achieved a pregnancy. Secondary infertility is infertility after another pregnancy was achieved, however that pregnancy ended. Has enormous impact on people psychologically. It impacts family relationships. It impacts their social lives. It may have religious implications and cultural dimensions, and it's often very devastating. It is not a woman's problem. Male factors, look at your pie chart here. 30% male, 30% female, 10% combined, 25% we don't know, and 5% marked as other. So it's equally likely to be a male factor and a female factor. Female factors, anovulation. Anovulation is an important word for you to remember. It means that you don't ovulate. Or infrequent ovulation. Hostile cervical mucus, it's either acidic or it's thick. Damage to reproductive organs like scarred or absent fallopian tubes or uterine abnormalities, and endometriosis is one of those. Other things, if you've had conizations of the cervix, it could impact your fertility. Usually not the ovulatory part of it, but male factors, low or absent sperm production resulting from a variety of things. Impaired sperm motility means you have enough sperm, but they don't move through the canal well, and erectile dysfunction. Now, the combined, you may have a man with low sperm production where he could get a highly fertile woman pregnant, but he's married to somebody with cervical mucus issues. That would be your combined factor. And sometimes we just don't know. You test for everything you can and you don't find anything. Okay, male factors, health history and physical exam. That's where every good assessment should start. And then usually the first test is a semen analysis. It's before you even test the woman for anything. They should provide a semen sample. It's non-invasive, it's not painful, and it's easy to do, and you'll get quick answers. They can do lab work for endocrine disorders that would impact fertility, male fertility. And they can do an ultrasound of the male reproductive system to identify any structural barriers. And obviously you would assess, as part of your physical exam, the genitalia and secondary sex characteristics. If it seems like the hair patterns or things are immature, that may indicate like more of a congenital thing going on. And here we have this little diagram. Sperm, normal sperm count, there's lots. Abnormal, lots of fluid, not a lot of sperm. Sperm morphology, sperm can be deformed. If you have a two-headed sperm, or you have sperm where the tail is not shaped appropriately. And then they look at motility. For example, do the sperm move through the fluid the way that they should? Okay, female factors. It's a lot more complicated, just like the systems are. Health history, including menstrual history and obstetric history. Hormone analysis. Thyroid, prolactin. It's such a delicate hormonal dance that triggers ovulation and sustains a fertilized ovum. They will also do a pelvic examination and look for any abnormalities of the uterus or structures. Assessment of secondary sexual characteristics. Again, if you have a woman who has underdeveloped sexual characteristics, that usually indicates a hormonal problem. It could be a congenital problem, like Turner syndrome, which is an extra X chromosome. You would assess for signs and symptoms of endocrine disruption, meaning anything that was a masculinization effect. For example, PCOS, polycystic ovarian syndrome, is a type of anovulatory insufficiency, right? Women either ovulate infrequently and the quality of their eggs might not be great, or they don't ovulate at all. They have unopposed male hormones in their circulation, and that has very obvious effects. It promotes hair growth in a male pattern. It can promote acne. It can promote truncal obesity. So there will be characteristics that you'll look for. Thyroid disorders, Graves' disease with the bulging eyes, or the goiter in a thyroid problem. So you would look for those things. You can do a pelvic ultrasound and examine the structures in a non-invasive way, or you can do a hysterosalpingogram, where they inject dye through the cervix into the uterus, and they watch where it goes on an X-ray. Sometimes the HSG is therapeutic because it breaks up adhesions in the tubes, but it will tell you if that fluid, if that dye gets stuck on any point in its journey from the cervix to the ampulla of the fallopian tube, you're going to see that disruption. Hysteroscopy, which is looking inside the uterus for abnormalities, and laparoscopy to look for things like endometriosis. Combined and unknown factors, they can do what's called a post-coital test. Couple engages in intercourse the night before the appointment, and then the female partner goes to the office and they examine the semen and vaginal secretions. They examine that under microscope to reveal changes to sperm and characteristics of the mucus and semen themselves. Okay, so now we're going to talk about assisted reproductive technology. I wrote therapy, I'll fix that too. This tries to address the root cause, or at least find a workaround, and they always try to go from least invasive to most invasive. But it's almost like a gateway. Once you start infertility treatment, most people are very reluctant to stop. It may involve lifestyle changes like weight loss or smoking cessation, all those things that we talked about that impaired fertility. If we can get that person in an optimally healthy state, we start there. Usually by the time they've gone through a year of unsuccessful attempts, it's a little bit beyond that. We can add complementary therapies like acupuncture. Most fertility specialists actually like using that as a complement to what they're doing, and they have seen higher success rates. Using ovulation predictor kits to determine if that patient is ovulating and when. And then we have things like intrauterine insemination, where let's bypass the vagina and the cervix and let's go directly into the uterus and inject that sperm. What they do in that case to optimize their chances, they take the semen sample provided either by the partner in that couple, the male partner in that couple, or donor, depending on what the actual problem is. And they kind of spin it so that it's only the good ones survive and they're kind of concentrated in one area. And they often use it with clomiphene citrate, which is an ovulation-inducing drug, to increase the odds of fertilization, because you don't want to waste time. So in vitro is more aggressive, and then there are more aggressive methods than that, but we're going to keep it relatively simple because you're not going to be experts in this stuff going through it today. In vitro, oocytes are fertilized in the lab, so they have to stimulate ovulation with the injectable medications. We're beyond Clomid now. And then the female partner has to have their eggs retrieved through laparoscopy. So that's surgery, and they do it under general anesthesia. Then they take the oocytes to a petri dish, fertilize them in the lab. You can use the couple's eggs and/or sperm, or donor eggs and/or sperm. Many times, if you are doing all of this, they are going to do some genetic diagnosis before they implant, because they don't want any abnormal embryos implanted into the uterus. So they'll grow them for a length of time until they're ideal for implantation in the uterus. Medications that we use for an ovulation. Clomiphene citrate is the first one. It's a gateway drug, really. But it's when you realize, yes, you have a problem with ovulation. It's an oral medication. If it doesn't work in 3 to 6 cycles, it should be evaluated. Is this really going to work? But no more than 12 cycles. So a person takes it starting on the 5th day of their cycle. They start taking the medication, and at that point, they should be having sex every other day for a week. So from day 5 to day 12. There's a slight risk for multiple gestation. You know, you might stimulate more than one egg. Twins are more common than higher order with this medication. And there's a slight risk of ovarian hyperstimulation syndrome. Gonadotropin therapy, this is now the big time. You inject, and the patient needs to learn usually to self-inject in a large muscle. I've helped friends with this. There is a much greater risk for ovarian hyperstimulation. It's generally used with IVF. There's a greater risk for multiple gestation. We used to see a lot of triplets and quads and higher order multiples because just like in a natural conception, the majority of embryos fail to implant. So they would use more than they needed, and sometimes they would implant 5 or 6, and you'd end up with 3. Now it's more common with the techniques that they use to implant fewer embryos and end up with twins and singletons, occasionally triplets. But it's generally used with IVF because at this point, if you're taking gonadotropins, you have tried everything else. And, you don't want to delay treatment. At this time, people might be allowed to, when they're doing the egg retrieval, they might be allowed to save the embryos for future use. That has become a little sticky in terms of certain states and how they define things. But that is something that they might take advantage of to give their child a sibling. Okay, your role in all of this, you assist with that health history and that physical exam. You might be responsible for obtaining that blood work and sending it and explaining it to the client. Educate the client about the lifestyle changes that they need to make to optimize their chances of getting pregnant and having a healthy pregnancy. Teach them the signs of ovulation, which you learned in the first video or coming all the way back around. Teach them how to use ovulation predictor kits. Teach them about the frequency and timing of intercourse, typically every other day during the fertile window. Expected effects, side effects, adverse effects of medication if they're on one, and the need to be on the doctor's schedule. This is one of the hardest things for people experiencing the infertility journey. It completely dominates your life. So if that doctor says you need to be here at 7 a.m. on Tuesday morning, that's when you need to be there. There's no rescheduling. It's all biology at that point. It's difficult with relationships, and people can be devastated by this. Our ability to have families defines, in some ways, our identity as male or female. And so couples experiencing this need a lot of emotional support. You should take a trauma-informed approach, do nothing to trigger further anxiety. And you might want to refer them to a support group like Resolve for dealing with the stress of this. Or if you suspect that there are more serious challenges, you can refer to a mental health professional. And this is the end of the road. Thank you for sticking with me.